Today we are going to study about the myxedema coma. So what is myxedema coma? It is basically ultimate stage of severe long-standing hypothyroidism, and it more commonly affects the older patients, more in winter months, and it carries a high mortality rate. Precipitating factors include exposure to cold, infection, trauma, CNS depressants, and anesthetic agents. These are the exacerbating and precipitating factors, that is hypothermia, cerebrovascular accidents, congestive heart failure, infections, drugs, anesthetic sedatives, other narcotics, amidrone, lithium carbonate, GI bleed, trauma, metabolic disturbance, uh, could exacerbate the myxedema coma. Other like hypoglycemia, hyponatremia, acidosis, hypercalcemia, hypoxemia, and hypercapnia. They usually present with a hypothermia, that is the first clue to diagnosis. Others are the myxedema, bradycardia, low BP, and seizures could be associated in 1/4 of patients, and altered sensorium, that is ultimately progressing from lethargy to stupor to the coma. These patients do have history of lethargy, slowed mentation, poor memory, cognitive dysfunction, and depression, even psychosis. But in background of impaired state of consciousness, they do not complain of these patients, these symptoms. But if we take the history, there may be significant symptoms as we have discussed, and there could be focal or generalized seizures may be seen in 1/4 of patients, possibly due to other factors, because of myxedema coma, that is hyponatremia, hypoglycemia, or hypoxemia, which is because of the reduced cerebral blood flow. There is a hypothermia which is present in virtually all patients and may be quite profound, and the ultimate response to therapy and survival has been shown to correlate with the degree of hypothermia. There is a worst prognosis in patients with a core body temperature which is less than 90 degree Fahrenheit. Regarding the cardiovascular manifestations, there could be non-specific ECG abnormalities, cardiomegaly in form of left ventricular dilatation and pericardial effusion, bradycardia, reduced cardiac contractility, and frank congestive heart failure could be possible in few rare cases. Hypertension, secondary to the decreased intravascular volume, leading cardiovascular collapse. Regarding the respiratory system, it could lead to hyperventilation, that is from the reduced hypoxic respiratory drive, and decreased ventilatory response to the hypercapnia, impaired respiratory muscle function, alveolar hypoventilation, that is progressive hypoxemia, and carbon dioxide narcosis and coma. Regarding the infections, patients may have normal temperature in spite of presence of infection, leading it is a clue for the infection, underlying infection, and may other symptoms like a form of diaphoresis tachycardia could be absent even in presence of infection. So there is a high chance of unrecognized infection and sepsis, and there is a difficulty in recognition of clear-cut signs, further leading to delayed treatment, and do increase the chances of mortality. There is a low threshold for the initiation of the systemic, and we should keep the low threshold for initiation of the systemic antibiotics. High degree of clinical suspicion is obviously required in such cases. We should get that thyroid profile done. And regarding the scoring system, there is a paper by that is Popevinuk et al., in which they have created a scoring system including the criteria in form of thermoregulatory dysfunction, that is temperature, CNS effects, GI findings, precipitating event, cardiovascular dysfunction, and metabolic disturbances. Regarding the thermoregulatory dysfunction, they have shown temperature, uh, that is more than 35 or 30 to 35 degrees Celsius or less than 32 degrees Celsius. CNS effects could be absent, somnolent or lethargic, obtunded, stupor, coma, or seizure. GI findings, anorexia, decreased intestinal motility, paralytic ileus, precipitating events could be absent or present. Cardiovascular dysfunctions in form of absent that is bradycardia and other EKG changes, pericardial pleural effusions, pulmonary edema, cardiomegaly, and hypertension. Metabolic disturbances, hyponatremia, hypoglycemia, hypoxemia, hypercarbia, and decrease in GFR are also the factors that are included in that scoring system. So a score of 60 or higher is highly suggestive diagnostic of myxedema coma, whereas score between 25 to 59 is suggestive of risk for myxedema coma, and a risk score which is below 25 is unlikely to indicate the myxedema coma. Other EKG changes that we have discussed in that regard also to be looked at, that is QT prolongation, low voltage complexes, bundle branch block, or non-specific STT changes or heart blocks that would contribute to that scoring system within the cardiovascular dysfunction. Regarding the hypothyroid, what is hypothyroidistic syndrome? In when some patient is sick, there is a pituitary TSH secretion is reduced, but in background of myxedema coma, it could be a difficult situation. So, some patient who is myxedema coma and also that is in background of also having that is sick euthyroid, so pituitary response may not be that much, and that could lead to TSH on the low side, but we should always be more careful while suspecting such cases, and we should look for unusually low T3 levels. Treatment is thyroid hormone replacement and correction of other physiological disturbances. In that, regarding the IV thyroid hormone administration is the preferred, which is levothyroxine in form of that is IV 500 to 800 microgram as a loading dose, which is followed by the 100 microgram OD IV. Other is liothyronine, that is 25 microgram every 12th hourly, combination treatment with T4 and along with T3 as a loading dose of 200 to 300 microgram T4 and 25 microgram T3, which is followed by the 25 microgram T3 plus 100 microgram T4 after 24 hours, followed by 50 microgram T4 OD. T3 versus T4 therapy, rate of extrathyroidal T4 to T3 conversion is reduced, and T3 has a rapid onset of action. T3 crosses the blood-brain barrier more rapidly. So yes, T3 is more, yes, it is better as compared to T4. And also the T4 levels won't vary much between the doses, whereas T4 has lower level risk of adverse effects. So these factors should be taken into account, that whether we have to use the T3 or T4, or even the combination may be used. Regarding the IV thyroid hormones, they do have advantage in form of getting early saturation of binding sites, predictable effect, rapid replenishment of the hormonal pool, and it is more preferred. But in some cases, if it is not available, then what can we do regarding the other issues? So even the oral levothyroxine is an effective option for myxedema coma if we don't have that IV available. So what is the usual regime, that if we clinically suspect myxedema coma, diagnostic criteria as we have discussed earlier, seeing multiple factors taking into account according to that scale, and if score is less than 25, then it is unlikely to be a myxedema coma. If between 25 to 59, there is obviously a risk of myxedema coma, and if his score is more than 60, that is diagnosis of myxedema coma. To ensure pre-treatment in these conditions with free T4 TSH till these levels are available, Always draw blood for the baseline cortisol, inject hydrocort along that IV to be given. And if baseline cortisol is less than 50, supplement IV hydrocort even every 8th hourly should be done. And once the patient is stable, then only we will do the ECTH stimulation test. There is no hurry in doing the ECTH stimulation test. If that patient does not have any CAD, or if that patient has CAD with normal LVF, or that patient is having CAD with left ventricular ejection fraction that is less than 60%, then that has to be treated differently. And we we may be very vigorous in increasing the doses of thyroxine in such cases, but yes, less rapidly increasing the dose of levothyroxine in these cases, those with CAD, and more towards lower side, little more lower side in these cases. So always check free T4 values every alternate day initially. So it has to be done every 2 days, and ensure the upward trend in free T4 to ascertain the effectiveness of oral free T4. But along with that, very important is to take the supportive measures in form of avoid any sedatives, treat the infection concomitantly, fluid management, ventilatory support, correct hypothermia, correct hypotension, hypoglycemia, look for hypocortisolemia. So these things has to be looked, as we have discussed earlier also. These all parameters has to be checked, that is CNS effects, GI findings, and these all parameters have to be checked concomitantly. So regarding the hydrocort, as we know that there could be a possibility of relative adrenal insufficiency as metabolic rate rises. Primary adrenal insufficiency cannot be ruled out, and if the pituitary disease cannot be ruled out, so always in background give hydrocort, that is in the form of infusion, or it could be given in the form of bolus dose, that is 100 mg at hourly, or if we are giving by infusion, then 5 to 10 mg every hour infusion can be given. Fluids, avoid hypotonic fluids. Water intoxication is there due to the reduced free water clearance of the hypothyroid patients. Hypertonic saline and glucose to correct the dilutional hyponatremia and occasional hypoglycemia. Other supportive measures in form of ventilatory support, supplemental oxygen. Warming with internal warming is preferred by gastric perfusion. Avoid external warming. It may lead to vascular collapse due to the vasodilatation, and blankets to prevent the heat loss, and temperature to be increased slowly in 24 hours in response to LT4. It occurs by the effect of LT4 itself. So do assess for coexisting in disease and take appropriate action for infection, cardiac disease, and cerebrovascular disease. So as we have already discussed that these myxedema patients may be febrile even despite the infection, and oral LT4 as soon as the patient starts taking orally. Prognosis, yes, there is a mortality remains high, although changed due to the better knowledge of because the recent advances, it has the mortality has come down, but still we have to be very careful. And these are the few scoring systems which could predict these mortality at the time of admission in form of GCS scoring, Apache 2 score, and SOFA score. So always we should have prompt recognition for managing case of myxedema coma. Diagnosis is largely based on the clinical grounds, and we should do urgently the thyroid profile. And treatment is there are mainly for these recommendations are mostly from the expert opinions and case reports. Enteral LT4 supplementation has good success rate in preventing mortality. These we have already discussed that in cases where IV is not available, even enteral LT4 supplementation is quite good. No definitive evidence to recommend combination therapy over LT4 alone. And supportive measures in treating the precipitating illness is also very, very important in the background. That is all the supportive measures as we have discussed. uh, Thank you.